Hello, everybody. My name is Elias Jabour. I'm very happy to be here and to co-chair the MDS session with my colleague, Dr. Garcia Manero. I know we're running late, and we try to be on time. There are a lot of things still happening in this city and in this hotel, so we try to be on time for the next 2 or 3 sessions. So the first speaker is Dr. Garcia Manero. He's Chief Section of MDS at MD Anderson, and he will go over the emerging target in MDS.
Thank you. I actually really enjoyed the morning. The presentations were outstanding, and the science that was presented was quite actually interesting and remarkable, but we are a little bit behind, so let's see if we can catch up. So my task today was to talk a little bit about emerging targets. If someone comes to the MTP session tomorrow, you will see that what we're thinking in MDS at MD Anderson is basically to break the disease in small groups, and we'll be discussing basically this in the next 15 minutes. So the first question is, can we target, or if there are reasons to target clonal hematopoiesis? So that's one. I'm not going to talk about TGF-beta targeting because I think Matteo de la Porta, at least in his title, says something about that and luspatercept, so I hope you're talking about that, right? I'm going to briefly talk about the oral hypomethylating agents in MDS, innate immunity. I think Matteo also has some in his title about P53 APR426, so I'm going to just briefly mention that, and then talk a little bit about some other potential targets. Okay, so the first question is, why would you target clonal hematopoiesis? So of course, this is an evolving field. This is data from Simona Colla, that is a basic investigator in our group in Houston, but she happens to be from Parma, really amazing scientist. And this is just an example, for instance, of a single-cell analysis of a patient with clonal hematopoiesis. And I don't have time to go through this, but if we compare this kind of analysis with a patient with low-risk MDS, they're actually virtually identical. There is no major difference. For me, one very interesting aspect of this concept is this connection between clonal hematopoiesis and comorbidities, let's say, in this case, atherosclerosis. And I think everybody is familiar with this concept, but the implication is quite important, because if the clonal origin of these cells that causes the MDS or the bone marrow failure and the cardiovascular disease is common, then by treating these patients, actually, you may actually affect not only the evolution of this disease towards MDS, but also perhaps the comorbidity. This is a paper that we just published a few months ago that I think is kind of interesting, where we look at the so-called CHIP mutations in patients with MDS, not patients with CHIP. And we wanted to see if there was a correlation between the mutation and particular comorbidity. I thought this was going to be a stochastic, meaning that there was not going to be any, was going to be maybe more mutations, more comorbidities. The surprise of this paper actually is that there was a correlation between the type of comorbidity and the type of mutation. That's unidirectionality in that sense. So I think this is important, because if you have particular mutation, you have particular risk of developing comorbidity, then you may actually have endpoints for very interesting clinical trials. And we have not treated anybody yet with CHIP or ARCH or CCUS, but we're starting to think about therapeutic perturbation. That will be like short exposure, trying to see actually if there is some degree of modulation with some of these interventions that are shown here in this slide. Not going to talk about luspatercept results, but of course this pathway of TGF-beta is becoming quite significant, because every time there is a new drug approved for disease, of course luspatercept is not yet approved, but we hope that it will be approved, and I think it's also going to have an indication beta thalassemia. Now, the way these drugs work is quite interesting. They don't really inhibit the receptor or the family of receptors. They basically serve as traps that avoid ligand binding to the pathway. I think there's going to be a very nice opportunity for a lot of research in lower risk MDS, particularly with multiple combinations, and I look forward to hear what Matteo says. Now, everybody knows this medalist trial that was presented at ASH's plenary session last year, showing very nice results in terms of hematopoietic red cell transfusion-dependent patients with refractory myelin sideroblasts that had failed already an ESA, with a drug that I think is quite safe. Of course, you cannot say that these DNA methyltransferase inhibitors are per se targeted therapy. But I think the 2 drugs that are coming hopefully next year are really going to transform our approach to patients with myelodysplastic syndrome. So the first one is this compound. It's called E727. This is actually a combination of decitabine orally with an inhibitor of cytidine deaminase that is basically the catalytic inhibitor of the drug. And what we did in this paper basically was to look at different ratios of combinations of the inhibitor plus the cytidine. And if you can look at the slide here, you will see that depending on the ratio of inhibitor plus the cytidine, you have AUCs that may be higher or lower. And this actually may give you a lot of opportunities to develop this type of compounds, not only myelodysplastic syndrome, but also in acute myelogenous leukemia. Now, I'm not going to show the data, but my group really helped develop CC486, that is oral azacitidine. This is the drug that went from phase 0 studies to phase 3 trials. We thought that this compound maybe was kind of dead, and we just got a press release a week ago that this oral azacitidine, that is a totally different drug with a very low AUC, has positive results in a trial of acute myelogenous leukemia, and very nice data that Valeria and I have seen in myelodysplastic syndrome. So we may actually have an opportunity to develop very interesting epigenetic regulators using different doses and schedules for our patients. Now, those patients that are treated with these hypomethylating agents, they tend to engage, this has been our experience, different inflammatory innate immunity type of pathways. So this slide summarizes 4 or 5 years of work where we performed ChIP-seq experiments looking at chromatin marks that are associated with active gene expression profiles. And every time we've done these experiments, we see the same pathway. That is basically innate immunity activation. So candidate proteins that are potential targets are toll-like receptors, of course, NF-kappa B, that is something that we've not been able to target, but then histone demethylases that are downstream of NF-kappa B activation. So we've worked quite a bit on this. We've developed actually a therapeutic platform. So this is a mouse model that overexpresses in the bone marrow compartment protein called Jumanji-D3 or KDM6B. These mice actually developed a low-risk aging-related myelodysplastic syndrome, and now we're crossing these mice with mice that have canonical mutations in MDS, using this actually as a therapeutic platform. What is interesting actually is that when we interrogate these mice, and we look, let's say, at RNA-seq experiments in this context, we see the type of pathway identical to what we see in patients with low-risk MDS, particularly in the context of HMA failure. As a proof of principle, a few years ago, we developed an inhibitor of toll-like receptor 2. This is one of the dominant receptors in this pathway, extremely safe compound with activity in terms of red cell recovery in these patients. And this very busy cartoon actually gives you an idea of potential targets that could have a therapeutic impact, basically looking at this concept of inflammation and innate immunity activation. So you see basically compounds that are already in clinical trials, including IRAK4 inhibitors, RIP1 inhibitors. We're actually ready to start a study with interleukin-1 inhibitor canakinumab. This actually will be very interesting for discussion, and also inhibitors of IRAK4. So these drugs are already in our clinics, ready to launch prospective clinical trials. In the prior talk, there was a question about what about immune checkpoint inhibitors. So this is a very simple paper from our group that I think kind of transformed this field. Here we just ask a simple question that was, in patients with MDS and AML, do you see expression of PD-1, PD-L1, CTLA-4? This actually came because there was data in solid tumors suggesting that if you treat lung cancer with a DNA methyltransferase inhibitor, you may see upregulation of this pathway. So what you see in this paper actually is that indeed, both in primary cells and in humans treated with epigenetic regulators, you see basically overexpression or triggering of this pathway. And with that, actually, we have launched both in AML, this is with Dr. Daver, and in MDS, a number of clinical trials using these compounds in combination with hypomethylating agents for patients with myelodysplastic syndrome. I think this data is of interest. So we see very high response rate. As you see there, response rates, complete remission with ACE and EVO as high as 40%. So this is really interesting. But we have been burned before with this idea that you get some signal of response in MDS, and then this translates into anything meaningful. What I think is actually interesting from these trials, and again, these are small pilot studies, is that we're starting to see median survivals that we have never seen before with an HMA or with any of the doublets. Now we're expanding these protocols. Dr. Kantarjan this morning was saying how potentially toxic this kind of combinations can be, and therefore we're doing this in the context of clinical trials. Just one word on this. This is interesting. This is an alternative immune checkpoint inhibitor. As it was discussed earlier, this is targeting macrophages, and we're talking particularly about CD47. The initial data using an antibody that targets this particular molecule reflects a 100% response rate in patients with MDS and AML. So we're moving very fast in terms of incorporating this type of compound to patients with MDS. What about targeting p53? This is something that I think if it was invited last year, there will be no way I could say anything. Hopefully Matteo will be showing this APR246 data, but this actually could really transform the care of a significant fraction of patients, at least at MD Anderson. I think in general practice, 8% of these patients have these mutations. At MD Anderson, this is actually close to 20% because we're a large cancer center where we see a lot of therapy-related myeloid neoplasms. We have now a quite significant effort trying to elucidate different types of mutations and different effects of BIFs on outcomes of these patients, but I think this is going to be, of course, a really important task. This is just one slide on this data from David Salman at Moffitt using this compound APR246. This actually binds directly to the p53 protein and is resulting in very striking response rates. Now, when this was first presented at EHA in Stockholm a couple of years ago, just a few patients, but the study open at MD Anderson is now on a phase 3 trial, and perhaps the response rate is not 100%, but it's quite substantial, and I think this is going to be an important compound. And then let's talk about a couple of maybe weird things, but if you have enough patients, this actually helps you start changing the patient. What about FLT3? Is FLT3 mutated in MDS? You're going to say no. Yeah, at baseline, basically 1% of these patients have this. But actually what we have published in 2 or 3 papers is that at the time of progression, around 20% of patients acquire or they have now detectability of an FLT3 mutation. And Dr. Ravandi actually published, not that this was linked to the story, but a very important paper a couple of years ago in Blood, actually adding back sorafenib, kind of, I'm not sure how potent a FLT3 inhibitor this drug is, and showing actually very significant responses without stopping the hypomethylating agent. So I think it's something that you have to pay attention in your practice. This morning we asked Dr. Falini about the NPM1. I think this is important, and again, this may be semantics, but if you call someone with 10% blast MDS, and then all of a sudden you get this NPM1 mutation, what we know now is that we can basically have almost 100% response rate with a cytarabine-based program, and if you transplant some of these patients, actually, you have almost universal cure. Interestingly, actually, these patients tend to be younger, so you can detect them, and you probably will be thinking about more intensive type of approaches here. Now, finally, in the last couple of minutes, and again, this is data from Simona and Irene Gagnan-Gomez in my group, is that we have investigated for many years now what is the effect of these hypomethylating agents in MDS. It's a no long story, actually, big paper is being reviewed as we speak. But what Simona has shown is that these compounds actually never touch the stem cell. So actually this is the problem with these hypomethylating agents. And that's probably why you need to give chronic therapy and all these things that the clinicians ask. So this is an example of different mouse systems where we have treated with hypomethylating agent. We see differentiation, but we never see eradication of these long-term stem cells. Now, what Simona has shown that I think is quite interesting is that these patients with myelodysplastic syndrome actually can be divided into 2 different groups. And this is actually agnostic of mutations, cytogenetics, etc. So we see a group of patients that have this GMP pattern and a subset of patients that are more CMP. And if you are interested, we can discuss this later. Why we think this is very important is actually when you look at this at RNA-seq level, we see totally different gene expression profilings. Actually, we see that some of these patients, in this case with the CMP pattern MDS, they will overexpress pathways where using a BCL2 inhibitor will make a lot of sense. And we see in the GMP pattern something that is actually totally the reverse. My suggestion to you is that I don't think venetoclax is going to be so easy in MDS as in AML. I think we're going to have a group of patients with very significant activity, and some of them actually where this drug could be a problem for the patient. So understanding the targeting, perhaps by identifying what is the stem cell that is affected and what type of gene expression signature they have, is going to allow us actually to test, to use these compounds. And we're actually testing this in a prospective clinical trial in patients with high-risk disease with this kind of combinations. So to summarize, actually, I think that targeting in MDS now from a clinical perspective, so forget about these RNA-seq experiments, is fundamental. Actually, I don't know how people can practice this disease without having genomic annotation. And this is just an example of how we structure our program at MD Anderson. So the patient comes with MDS, they may have CHIP, we're thinking about what to do with those patients. If you go to the, I guess, the right of the slide, you see now that we start having drugs that may have significant activity. We have ongoing trials against IDH1, IDH2. Some of this data actually will be presented at ASH. We discussed very nice data with FLT3 inhibition in a specific subset of patients. MPN1, hopefully when we hear this data, very significant activity with drugs that modulate p53. The splicing so far has been more disappointing. We thought that a couple of drugs in development may be very positive, but they have some side effects, so we are not there yet. And then when we come to actually non-mutatable, targetable type of MDS, I think these newer forms of debilitating hypomethylating agents are really going to help us substantially. And with that, I actually made it on time, so hopefully we'll start recovering. I'm extremely, again, grateful to this opportunity to be here with you and learn from all these talks. Thank you, Ali.
Maybe one burning question. Okay, please.
You know that about 20% of myelodysplastic syndrome are therapy-related. I know the therapy-related myelodysplastic syndrome are classified together with leukemia secondary. But in my opinion, this exists, the form of myelodysplastic, remain myelodysplastic. And then my question is, the test, the mutation, cytogenetics, have the main significance in myelodysplastic syndrome and therapy-related or de novo, and the oncogenetic pathways is the same in these two forms? Because it is the same. I think it's not right to classify the myelodysplastic syndrome together with the leukemia, because also in the myelodysplastic syndrome therapy-related, there are some difference, as there are some difference between the therapy-related leukemia. For example, the promyelocytic leukemia therapy-related is a form of good prognosis. And then this classification, in my opinion, is misleading.
I think this is a very important question. I'm going to answer it quickly. But I think what you are saying, and I totally agree, so I will repeat your question because I agree with is that I don't think we should just call all these people the same. And I think that now we have the tools actually to call these patients with therapy-related or the secondary type of process different based on their cytogenetics, the type of mutational, and most important actually the BAF of these mutations. Because a patient with quote-unquote therapy-related disease that is diploid with a BAF of p53 that is extremely low, according to our data, that patient does extremely well with whatever therapy you select. So I think you are right on target. Now, this morning with Dr. Falini, we were discussing this. Is this semantics? I don't know what is first, but I think the key here for the practitioners in the room is not to go for the label of this name, but to go deep and understand what is the cytogenetics, what is the molecular, what is the BAF, and then put that in context and treat them accordingly. I totally agree with you.
Thank you, Guillermo. I want to move to the second talk. It's my pleasure to introduce Professor Valeria Centini, who will discuss with us how she managed MDS in Italy. Valeria.
Thank you, Elias. After the outstanding talk of Guillermo, I think we are just down to earth now with our data in Italy. And how do I treat patients in Italy? This is just to show you that we try to build a network that is actually quite successful. So we included in our network that is an epidemiology, but also scientific and a clinical network, all the Italian areas and regions, apart from two small ones that we will try to involve very soon. We have at present 4 clinical studies ongoing, experimental studies that we promoted in the registry and within the FISM. So what are we talking about? We have in the registry and followed up around 5,700 and more cases. And as it is known in literature, the majority of our patients do belong to the lower risk IPSS and IPSS-R. This is consistent with previously published data. We follow this patient from diagnosis up to therapy and several lines of therapy, collecting all the clinical and cytogenetics, flow cytometry, and molecular data. And I want just to spend very few words, because you heard much about it, about the evaluation of somatic mutation in MDS. Now, it is very interesting and promising, not only from a scientific point of view, but mostly for everyday life, because there is a possibility, as you heard, of target therapy. And another point that has not been touched yet is the fact that we may characterize patients, and this is what we are doing within the registry, inherited predisposition that allows us to choose a better therapy, especially in the issue of, and in the case of transplant. And as Matteo has worked a lot on this, we have mutations that are giving us a very important and prognostic indication in case of transplant. So this is what we are actually busy with. And in fact, we allied with several other centers all around the world. And these 4,000, almost 5,000 cases of MDS have been collected all over the world and studied very, very carefully. And as you heard from Torsten Afferlach, the level of the molecular evaluation is very deep, and we hope to have finally a response to how can we integrate IPSSR with the molecular data and the mutation of MDS and establish what is the best target therapy and choose the best therapy, as we heard from Guillermo as well. So, as far as we are now, we have very few solid data. One is the fact that the number of mutation, irrespective of the kind of mutation, is important for overall survival. Any type of therapy will just give you the same result. If you have many mutations, your overall survival is going to be shorter. And then we do know, and you just heard a few words about it, that the mutation of P53, and we have evidence that the B allelic mutation is much more, has a worse prognosis than the monoallelic mutation, is impacting also from this work of ours clearly, even if you have, it's even worse than the complex karyotype in terms of overall survival. And you hear about a therapeutical approach about it. What do we do in lower risk? So in lower risk MDS in Italy, we have quite a number of choice. And you know that the first therapy of choice, given the fact that anemia is the most frequent cytopenia, is using ESAs. And ESAs have been approved recently in Europe so that we may finally use them. Actually, APO-alpha has been approved. And the first step, again, is to measure EPO, endogenous EPO level. And then if you fail therapy with ESAs, then you have for non-del(5q) experimental agents, mainly in Europe. Hypomethylating agents are not allowed, so they will be in controlled studies. Whereas if you have del(5q), you should assess TP53 mutation and then proceed with lenalidomide in case of absence of mutations. So if you have other cytopenias in Italy, you are not allowed to treat with any drug, standard drug, apart from immunomodulation, cyclosporine, ATG. Otherwise, everything is experimental. And as you know, only younger patients can have an advantage from therapy with immunosuppressive drugs, and they're actually quite underused in MDS. And finally, even in lower risk MDS, we may discuss the opportunity to go to transplant. So I just mentioned the fact that finally we had the approval on data that are less good than we expected for ESAs. So these are the study in which actually heterogeneous population, difficult design and difficult schedule led to the approval of the drug, despite the fact that you had, only 31% of response. So what do we do when we do not have response? You saw that we can approach the patient with an off-label drug like lenalidomide, and you have to select the patient, because otherwise only 27% of them will respond. Whereas if you base your choice on the level of endogenous EPO at the moment of relapse, you may actually achieve as much as 42% of response if you do not have a patient who's carrying SXL1 mutation that is giving you, as you see, resistance to lenalidomide, whereas the mutation of DNMT3A and EZH2 are let's say, variable that correlate with response. So you may select patients. And in fact, this is not just data that you cannot translate into overall survival. You see that if you treat patient with a mutation of the DNMT3A with lenalidomide, your overall survival is significantly different from the one of patients with the mutation and treated with placebo. So we do obtain something. I'm not going to stay on this slide more than 1 second because it has been already discussed. So in Italy, we had the possibility to treat a lot of patients within the Medalist trial. Now we are only following up the patients and waiting for the approval of the drug. And this is another approach that was developed also in Italy. It's an international trial, though. The approach, the molecular approach, is completely different because imetelstat is a drug that is actually targeting the telomerase and therefore can be active in patients with MDS who have a shortened telomeres. And in this phase 2 trial, as you see, the 42% of patients obtain transfusion independence. Now we are opening the phase 3, and in Italy, several centers are involved. This is an all-Italian study that is possibly starting in these days. This is an interesting trial promoted by our foundation and our registry, and is led by Emanuele Angelucci. So the idea is that if you chelate very early MDS patients who have transfusion dependence but not a high burden of transfusion, you may avoid and prevent iron overload and prevent the damage. So the idea is to treat for 1 year, follow up this patient with the Ferazerox 3.5 milligrams per kilogram, and assess monthly if you have a lowering of NTBI, LPI, and we want to check whether tissue damage and organ damage is delayed. 60 patients will be enrolled in this study, and as I mentioned to you, enrollment has just started. What do we do for high risk? Now, what is the difference on this very old algorithm that I presented 7 years ago already? Not much. I just marked in lighter blue the fact that we do not use any longer IPSS, but we do prefer IPSS-R. And then together with evaluation the comorbidity, we do evaluate with NGS the mutations to establish what is the best and most rapid approach to this patient. For the rest, of course, the patient with higher risk MDS have to be considered immediately for transplant, and if they have a donor, just go to transplant either with the preparation of hypomethylating agents or chemotherapy, and the discussion here can last for the rest of the evening, but I will spare it to you. And of course, there is also the discussion of whether transplant patients upfront without any debulking therapy. If the patient has, in the great majority of cases, is old or has some comorbidity, you are stuck with hypomethylating agents. And if as you know, only azacitidine is allowed in Europe. When the patient loses response, we have again to evaluate mutations. So repeat what we did at diagnosis. And what we are left with are just investigational drugs. Because it has to be kept in mind that the response to hypomethylating agents ranges from 6 to 26 months. All our patients will lose response in the end. So what do we do afterwards? We actually checked in our register, 92% of the patients stopped azacitidine treatment in 3-year time, and the median time to drug discontinuation was 8 months. In 45% of the cases, because they first responded and then lost response, 24% of the patient had some toxicity or didn't come for treatment because they had no caregiver or something like that. Progression to AML was only 14%, primary resistant was 11%. And very unluckily, but only 6% of the patient did undergo the transplant as we wanted to plan. So the efforts are now in changing these numbers and try a first-line therapy or a target therapy that may improve or rescue these patients. So what do? We need some super drugs, and what do we have in Italy? We have, you already heard something, but we have guadesatabine. Guadesatabine has been evaluated now in a phase 3 trial in patients with MDS who lost response to hypomethylating agents, and the data are still pending, but you know, as you see, that 60 or 90 milligrams in previous study were showing quite good results if the drug was given as the other hypomethylating agents for a long time. So the exposure to this drug should be longer, and so the hypomethylating effect longer and more effective. So we're waiting for the guadesatabine versus placebo data in some time. And you already heard about this. Unfortunately, even if we start the study in these days, this is a phase 1-2 study in which we will compare the Aztec 727, that is the oral decitabine, so a CDA-resistant decitabine, with the IV decitabine. Unfortunately, in the entire world would be high-risk MDS and AML, and in Europe would be only AML because decitabine is registered only for AML. Then this is a study, again, another drug that you already heard about is CC486, so the so-called oral azacitidine. I have proposed, and I will start this study only with, with only 10 patients. Is a pilot study of maintenance in patients with high-risk MDS who achieved a stable response with sub-Q azacitidine, and they will be maintained with CC486, and we will, the endpoint assessment will be the feasibility and the possible toxicity and safety of the drug. So will be at least 6 cycles with oral drug until progression in a small number of patients, and is a phase 2 study. We already had, of course, again, about the IDH1 and IDH2 inhibitors. The data that were shown together with the data in AML that brought the approval of both drugs were related to very few cases of MDS in which it was obtained a very high overall response rate. And you heard the data this morning from Andy Anderson that are really very interesting and very promising, even in relapse refractory MDS. In Italy, we have this trial that has just finished, high-risk MDS, azacitidine plus enazidenib. And what we are also going to have is ivosidenib in patients who are higher risk MDS after failure of hypomethylating agents without overt progression to AML, and of course carrying IDH1 mutation. But together with EMSCO, so the European platform, we plan to have also an arm in which untreated higher risk MDS that do not have a very profound cytopenia will be treated with ivosidenib, and azacitidine will be given at certain dose after 3 months of 3 cycles of ivosidenib. And in the end, a very interesting approach will be lower risk MDS who lost response to ESAs. So a lot of combinations, not many available in Italy actually. and hypomethylating agents and HDAC inhibitors will not be proposed any longer because none of the study has been really good, as well as the other molecules here mentioned. And with this, I thank you for your attention, and I'm ready to answer any questions.
Thank you very much. We'll take one question. No, well, for the sake of time, I want to skip the question then.
Okay.
I want to move to the next speaker. Thank you very much, Valeria.
So thank you, Valeria. That was really excellent. So the next speaker is Dr. De La Porta from Pavia, who is going to talk in more detail about some of these pathways that Valeria and I have discussed. Thank you, Matteo.
Thank you, Guillermo. And first of all, let me thank... Yes, I just moved to Milan. So first of all, let me thank Giovanni and Claudio for this kind invitation. So we discussed that in MDS, some years ago, several recurrent genetic mutations were identified. And there is an increasing evidence that this mutation may have a prognostic implications in MDS and may improve the capability to capture prognostic information at individual patient level with respect to conventional hematological and clinical parameters. So, for instance, we know that patients affected with SFTB1 isolated mutation are associated with good prognosis, while some other mutations, including TP53, RANKS1, SXL1, and other splicing-related mutations, are associated with a reduced probability of survival. So currently, several efforts are ongoing in order to correctly integrate mutational screening into clinical decision-making in MDS patients. And for instance, within the Italian clinical MDS network, we performed a partitioning analysis in about 700 MDS patients. Partitioning analysis is a technique, is a statistical tool that is able to identify clusters of patients with homogeneous prognosis. And as you can see here, several clusters that we have identified were closely associated with a specific mutational pattern. So during this presentation, we'll mainly focus on two clusters, that is TP53 mutated patients that, not surprisingly, were associated with the worst prognosis, and two patients characterized by the presence of ring sideroblast and SFTB1 mutation that are associated with a good probability of long-term survival. So what about TP53 mutation? The first evidence that the clinical utility of TP50 mutation screening in MDS patient by NGS was provided recently in the setting of MDS associated with isolated deletion of chromosome 5. We know that this group of patients are associated with a good prognosis, but there are a quite clinical heterogeneity. So I mean that a group of patients, about 10% of patients, despite the presence of isolated 5q, tends to rapidly evolve into an overt acute myeloid leukemia. And this clinical heterogeneity can be explained by genomics. And these patients are characterized by the presence of TP53 mutation. This means that TP53 mutation among patients with 5q deletion identify a group of patients with high risk of leukemic evolution and a low probability of response to lenalidomide. So in last years, several groups addressed the issue of the clinical relevance, of the possible clinical significance of mutational screening in predicting post-therapeutic outcomes in MDS, with a special focus on allogeneic stem cell transplantation that represents the only curative option for these patients. For instance, in the context of the Italian group of transplantation, we studied 400 MDS receiving transplantation in last 10 years in Italy. And we were able to identify 3 different mutated genes, that is RANKS1, SXL1, and TP53, that were independently associated with an increased risk of disease relapse after the transplant procedure. And in our study, as you can see here, TP53 mutation was the most relevant feature that was associated with the probability of transplantation failure. So the Boston group provided a more extensive study on 1,500 MDS receiving transplantation that provided new relevant clinical findings. As you can see here again, TP53 was the most relevant parameters associated with the risk of disease relapse after transplantation, while among TP53 unmutated patients, a RAS pathway mutation and JAK2 mutation were associated with an high risk of disease relapse and high risk of transplant-related mortality, respectively. So the Seishio Ogawa group in Japan recently clarified that the clinical impact of mutation in RAS pathway was limited to those patients that were affected by a mixed myelodysplastic myeloproliferative neoplasm. So that from a clinical point of view, to date, TP53 mutation was the only clinically relevant molecular parameter associated with post-transplantation outcome prediction. So in the clinical practice, how we can improve the post-transplantation outcome in patients with high risk of transplantation failure because of genotype, because of, for instance, TP53 mutation. So from a theoretical point of view, we can consider to anticipate transplantation in earlier disease stage, to define new conditioning regimens in order to improve our capability to eradicate the MDS clone, and last but not least, to consider preemptive therapies after transplantation. So, as you know, recently, hypomethylating agents, and in particular the cytarabine, were found to be able to provide a transient decrease of TP53 mutation in MDS and AML patients. So there is an increasing interest to include hypomethylating agents as a part of a comprehensive strategy to improve post-transplantation outcome in TP53 mutated patients. So, but as discussed by Guillermo, in the next future, we have to move to specific therapeutical strategies based on inhibitor of TP53 pathway. So we came back to our cartoon for the classification of prognosis in MDS according to both clinical and molecular parameters, and we moved to consider SFTB1 mutated patients. As you know, SFTB1 mutation is closely associated with the presence of ring sideroblast from a phenotypic point of view, and this cluster of patients is characterized by a low probability of leukemic evolution, and this means that severe anemia among these patients represents the most relevant prognostic factor. So the aim of treatment in this specific clinical setting should be to improve ineffective erythropoiesis and anemia. So in this context, as you know, recently luspatercept was found to be able to provide a selective inhibition of TGF-beta superfamily and to provide efficacious stimulus of late-stage erythropoiesis, both in MDS experimental models as in patients, as demonstrated in the first phase 2 study, in which, especially in patients with ring sideroblast and SFTB1 mutation, luspatercept was able to improve anemia and transfusion dependency. So now randomized phase 3 study was completed, focused on patients with ring sideroblasts, as you can see here, comparing luspatercept versus placebo in the treatment of anemia in this setting of low-risk patient with ring sideroblast. So as you can see here, more than 230 patients were randomized in this study. The median age was about 70 years. A significant proportion of patients were affected with an high transfusion need and presented high endogenous HIPO levels. And as you can appreciate here, in most patients, SFTB1 mutation was detected. So the primary endpoint of the study was to evaluate the transfusion independency at 8 weeks, and this endpoint was achieved in luspatercept arm in about 30% of patients versus about 10% of patients enrolled in placebo arm. And in a responding patient, the duration of transfusion independency was about 30 to 40 weeks. So what about luspatercept in low-risk MDS? So treatment with luspatercept is associated with an high percentage of patients that achieve red blood cell transfusion independency. Erythroid response is durable with a significant proportion of patients achieving transfusion independency with that maintains this response at 1 year of treatment. So importantly, in this setting of low-risk patient, luspatercept was well tolerated. So we can conclude that luspatercept is a promising new treatment option, at least for low-risk patients with ring sideroblast and maybe SFTB1 mutation. So to conclude, there is increasing evidence that mutation screening may add relevant prognostic information at individual patient level in MDS. TP53 mutation may affect clinical decision-making in MDS, and in this specific setting of patients, I think that we have to think in the next future on the use of specific drugs that are able to target TP53 pathway. On the other hand, in low-risk anemia, in low-risk MDS, anemia is the most relevant prognostic factor. So this means that the aim of treatment of this patient should be to improve anemia. And at least in patients with ring sideroblast and SFTB1 mutation, luspatercept is a promising new therapy for the treatment of transfusion-dependent severe anemia. Thank you very much for your attention.
Thank you. Now, he finished 3 minutes ahead, so only one question. Okay, I'll ask you a very quick question. What do you do with a P53 mutated MDS patient when you make decision for transplant?
So I think that, so at least we have to consider to provide transplantation in early disease phase. We know that the disease status at transplantation is one of the most relevant factors affecting the probability of transplant successful. So I think that at least in this patient, we have to move to an early transplant strategy, also in patients diagnosed in low risk, in conventional low risk MDS.
Okay, thank you. So we're gonna, thank you very much, Matteo.
Thank you.
So we're gonna move to the next speaker, Dr. Papayanidis, who's gonna talk about systemic mastocytosis. Thank you very much.
Thank you, Dr. Garcia Manero and Dr. Jabbour. Good afternoon, everybody. So it's a great pleasure for me to be here today, and the topic of my first talk in this meeting is systemic mastocytosis. These are my disclosures. So just a brief introduction for those who are not familiar with this disease. It's a very rare neoplastic disease characterized by the uncontrolled proliferation of mast cells in one or more organs. As a consequence, mast cell activation leads to debilitating symptoms, thus defining a very heterogeneous disease from a clinical point of view. In about 95% of the cases, KIT D816V mutants are responsible for the growth and activations of mast cells. And as per WHO criteria, we can recognize, on one hand, indolent or smoldering forms, on the other hand, advanced forms characterized by organ damage and including mast cell leukemia, SM with an associated hematological neoplasm, or aggressive SM. As you can see here from this graph, patients with indolent SM have a quite normal lifespan. On the other hand, patients with mast cell leukemia have a very poor prognosis. c-KIT is not the only one gene responsible for onset disease. There are many other mutations, in particular the so-called SAR mutations, standing for SRSF2, ASXL1, and RANX1, may be detected in patients and may be responsible for a worse outcome, as recently also confirmed by this paper published just 2 weeks ago in JCO. So how do we treat these patients? It depends on the subtype of SM we have to treat. On one hand, for indolent or smoldering patients, we just have to avoid triggers of MC degranulations. If we have symptoms, we have to start with an anti-mediator therapy. But if patients have no symptoms, just follow-up and controls are required. On the other hand, if we have patients with an adverse form of systemic mastocytosis, a treatment is strongly recommended. And we have many options, but today I want to focus your attention on the one compound, which is midostaurin, which has been approved for this disease for patients with c-KIT mutations, and on imatinib, which on the other hand is approved for patients without c-KIT mutants. We have also option in terms of chemotherapy, cladribine in particular, and we have interesting data on new compounds, in particular avapritinib, and I'll show you some data. However, as we say for the majority of hematological malignancies, allogeneic stem cell transplantation is the only one potentially curative option for these patients, and I'll show you data also about this. Starting from chemo, cladribine in SM has been tested, and this is the most important paper on this topic. It's a French experience on a retrospective cohort of 68 patients, 32 with an advanced systemic mastocytosis, showing an overall response rate of 50% with a median duration of response of 2.4 years. Immunosuppressive and myelosuppressive effects are a major concern, in particular neutropenia, prolonged lymphopenia, and many infectious complications. So last year, midostaurin has been approved by IFA, our regulatory committee, for treatment as monotherapy of patients with advanced systemic mastocytosis. And I'm showing you the results of the most important trials. In particular, I want to focus your attention on the first one, which was published in New England Journal of Medicine 3 years ago, exploring the activity of the drug. It was a phase 2 trial involving 29 sites worldwide and enrolling 116 patients with advanced SM, relapsed or progressed after no more than 2 prior therapy regimens, receiving midostaurin at the dosage of 100 milligrams twice daily in continuous cycles of 28 days until disease progression or unacceptable toxicity. 89 patients were considered evaluable since they had at least one measurable C finding, which was identified by a specific study steering committee. The primary endpoint of the trial was to assess the best overall response rate, and the secondary endpoints were safety, duration of response, PFS, overall survival, and toxicity. Exploratory endpoints were disease symptoms, assessment, and quality of life. You can see in this table patients' characteristics. The majority of the patients had a systemic mastocytosis with an associated hematological malignancies, and more than 50% of the patients had more than 3 C findings, so defining a very, very poor populations. What about response? The overall response rate was 60%, with 45% of major response and 15% of partial response, with a median duration of response of 2 years and a median overall survival of 29 months. And the median duration of response was not reached in ASM and in mast cell leukemia patients, as you can see here, and median overall survival was not reached as well in aggressive systemic mastocytosis. In a multivariate analysis for overall survival, you can see that the subtype of systemic mastocytosis, having received a prior therapy, the achievement of response and the reduction of mast cell burden in the bone marrow of more than 50% were linked to a better outcome. Important effects in terms of reduction of bone marrow mast cell burden, serum tryptase level, and spleen volume were observed in the majority of the patients, as well as an improvement of the majority of the symptoms, with the exception of nausea and the vomiting that we all know also from our experience in AML that are the most important adverse events that patients complain when they get midostaurin. In terms of toxicity, a low incidence of grade 3-4 non-hematological adverse events occurred, and about 20 to 40% of the patients developed an hematological adverse events of grade 3 to 4 in terms of anemia, neutropenia, or thrombocytopenia. The other studies confirmed the same results in terms of overall response rate, major response, and partial response. So midostaurin seems to be very effective in this field. However, as I told you before, maybe allogeneic stem cell transplantation is the only one potentially curative option for these patients. About this topic, we don't have prospective trials, so we just have this experience published in JCO 5 years ago, assessing the role of allogeneic stem cell transplantation on 57 patients with advanced disease. And you can see here from the graph that the overall survival at 3 years was only 17% for mast cell leukemia patients, 43% in aggressive SM, and 74% for patients with an associated hematological malignancies. And as expected, a worse outcome was observed for patients who underwent stem cell transplantation with a resistant disease. A consensus opinion on allogenic stem cell transplant in systemic mastocytosis was published 3 years ago, suggesting the use of midostaurin from the beginning, alone or in combination with polychemotherapy, followed by allogenic stem cell transplant for fit patients, of course, and it strongly suggests the reintroduction of TKI, as we usually do also for Ph positive or for FLT3 mutated AML, if patients don't have GVHD or other comorbidities, but at a lower dosage. What about new drugs? The most interesting one, in my opinion, but it's not only my opinion, of course, is avapritinib, another oral c-KIT inhibitor, which was tested in a phase 1 so-called Explorer clinical trial, which included a dose escalation part, 32 patients, and the part 2 with an expansion phase, which enrolled the patients with advanced systemic mastocytosis, and the primary study objective was to identify the overall response rate as per the IWG ECNM criteria. You can see here that 39 out of the 69 patients enrolled were evaluated according to these criteria. They had all advanced systemic mastocytosis, and 95% of these patients had the D816V mutation. About 26% of the patients had already received midostaurin during their past medical history. And what about the results? An important reduction in more than 50% of the patients in terms of serum tryptase level, burden of marrow-KIT D816V, bone marrow mast cells, and splenomegaly was observed in this cohort. And in terms of overall response rate, 77%. And I want to focus your attention on the fact that 73% of patients with the SAR genotype I mentioned before obtained a response. The median overall survival was not reached for any subtype. And in terms of toxicity, most adverse events were grade 1 or 2. Cytopenias were most common grade 3 adverse event related to treatment, and only 4% of the patients had to discontinue treatment due to therapy-related adverse events. We all know that mast cells may express in about 50% of the cases CD30. So brentuximab vedotin has been tested. This is a paper published last August by the group of Jason Gottlieb. 10 patients treated with this drug, but very unsatisfactory results, 0 responses, just stable disease and progression, and no improvement in terms of reduction of serum tryptase level or clinical symptoms. We are receiving some suggestions in terms of potential curative approaches from our lab. Simona Soverini in Bologna, working with me, published this paper last year in Leukemia, showing that in advanced systemic mastocytosis there is a reduced or absent SETD2 protein expression, and that the treatment with the proteasome or aurora kinase inhibitors alone or in combination with midostaurin is able to rescue SETD2 expression and to induce apoptosis and to reduce the growth of neoplastic mast cells in advanced cases. So, to conclude, take-home messages. SM is a very heterogeneous disease which requires a multidisciplinary approach and management. A molecular assessment in advanced patients may identify the most aggressive subtypes. Today, midostaurin is the standard of care in advanced patients, overall response rate of 60%, as I told you before. However, allogenic stem transplantation could be the only potentially curative approach, but we don't have prospective trials, and we need a very specific expertise, I think, also from a clinical point of view to manage these patients. Avapritinib showed promising data, and there are two phase 2 trials currently ongoing in Europe, in Italy as well. And we are waiting also for these results. Interesting data from the lab in order to identify new approaches for these very poor patients populations. And I want to thank all my colleagues working on mastocytosis in Italy, our Roma ECNM competence network, the Italian Association on Mastocytosis, my colleagues from Bologna, of course my mentor, Professor Giovanni Martinelli, and you all for your attention, and I'll be happy to take questions.
Thank you, Christina. That was excellent. You have 3 minutes, so one question. Where? Hagop.
So two quick things. Excellent presentation. It looks like avapritinib may change the whole course of advanced mastocytosis. So in those 39 patients, do you have an expectation on the survival? Is it at 2 years, 90%, as opposed to historical survival of less than 2 years? Or?
I think it's early to have some data in a prospective way. However, I think there will be a very strong difference if compared to what we are used to see with cladribine or with midostaurin on other compounds. But yes, I think it's a breakthrough if compared with what we had before.
And in patients who are less than advanced systemic mastocytosis, should they be seen in cancer centers or just in regular medical practices, like for control of symptoms and so on? Why can't we not use avapritinib for the less advanced to just eliminate their disease?
There is a clinical trial ongoing also in indolent forms, and I think that these results may be important to give an answer to your questions. It's ongoing. I think it could be rational to use it before in order to avoid the progression or to improve symptoms, and so not to see the bad clinical pictures that we are used to see in advanced cases.
Thank you, Christine. I think Dr.